That's fine with me.
Yeah.
Okay. Well,
Fine.
it's really my pleasure today to introduce to you our three speakers, Dr. France Tavola-Daly and Dr. Sharon McKenzie from Kean University and Dr. Nancy Richardson from University of Southern Maine. I'm really excited about this presentation because both Dr. Daly and Dr. McKenzie are two of our faculty scholars in our Faculty Development Collaborative program, and I was so delighted to have them representing therapeutic recreation because it is such an area of importance in geriatrics, and they both have a wonderful background in things that we're interested in.
Just hit down.
So I'm going to do little bio sketches on everyone. Dr. France Tavola-Daly is an associate professor at Kean University in New Jersey, where she's program coordinator of the Recreation Administration Program and Recreation Field Placements in the Department of Physical Ed, Recreation, Health, and the College of Education. Dr. Daly's been a faculty member at Kean for over 23 years. She has an MA in Therapeutic Recreation from NYU and a Doctorate of Education in Health Education and Therapeutic Recreation from Temple University. Her areas of interest focus on therapeutic recreation with people with intellectual disabilities, aging experience for people with intellectual disabilities, inclusion across the lifespan, Alzheimer's disease, and community-based services for older adults with and without disabilities. She's presented at over 30 international, national, state, and local workshops and conferences on various topics on therapeutic recreation, aging, and disabilities. And her proposal, Inclusion, ADA, and Senior Centers, was recently accepted as a presentation at the American Society on Aging Conference in 2014. She also co-authored a textbook in 2010 with Dr. Robin Kunzler on therapeutic recreation leadership and programming. She's currently working on a research project with Somerset County Parks Commission Therapeutic Recreation Department to assess effectiveness of their inclusion program model. She's also currently working as a mentor and advisor for the university's 21st Century funded grant for an after-school program in Hillside, New Jersey. Dr. Daly is also active in professional societies in the recreation and therapeutic recreation field and is a past president of the National Therapeutic Recreation Society. Dr. Sharon McKenzie, our other speaker, is an assistant professor at Kean University in the Department of Physical Education, Recreation, and Health. She received her PhD in education with an emphasis in therapeutic recreation and minors in gerontology and complementary and alternative therapies from University of Minnesota. She also has an MS degree in clinical investigations from NYU School of Medicine. Her intellectual interests range across the mental and behavioral health disciplines with a focus on facilitating the education about dementia and Alzheimer's disease in minority communities and promoting positive lifestyles for older adults. Dr. McKenzie completed a 3-year NIA postdoctoral fellowship in clinical investigations at the Medical University of South Carolina. The tenure for this training was completed at NYU School of Medicine, Silverstein Aging and Dementia Research Center. During her postdoctoral training, she was a junior investigator and co-PI on 2 NIH-funded pilot intervention studies, both of which aimed at integrating clinical investigations into community-related research. After her postdoctoral training, in addition to her other consultant positions, Dr. McKenzie supervised the geriatric training program for physicians, providing education in cultural competency and qualitative research techniques at SUNY Downstate. As a clinician, Dr. McKenzie has worked in both subacute and long-term care settings in the roles of a certified therapeutic recreation specialist and a director. In her current position, she teaches courses in therapeutic recreation, aging, and leisure in a multicultural society. She is also a certified dementia practitioner and is certified to provide training about dementia and Alzheimer's disease to healthcare workers and families. She also currently holds a minority investigator research grant funded by the Alzheimer's Association, investigating cognitive health perceived needs among minority older adults. Her publications range in topics including rec therapy for older adults, role of sleep in minority communities, reminiscence, and life review as therapeutic intervention for individuals with early stage Alzheimer's disease. And we're delighted to have another guest with us, Dr. Nancy Richardson, Professor of Recreation and Leisure Studies, Coordinator of Gerontology Certificate Program. Dr. Richardson has been at the forefront in developing recreational therapy interventions for use in the care of older adults. Non-drug psychosocial interventions are important alternatives because these pharmacological treatments have limited effectiveness for certain behaviors in older adults with dementia and can have serious side effects. We know that full well because we've certainly discussed it in our presentations here. So that even emphasizes more than ever how important therapeutic recreation is. Dr. Richardson's research interests include creating evidence-based practice in recreational therapy by testing the effects of these types of interventions as animal-assisted therapy, Reiki, pedometers, in addition to coordinating the University of Southern Maine's online gerontology program. She teaches a variety of courses in the Recreation and Leisure Studies Department, as well as health and geriatric-related coursework focusing on wellness, education, and health in later years. Recently, Dr. Richardson and her colleagues developed a recreation therapy assessment in long-term care entitled the Band-Aid RT. She has been on the board of directors for the American Therapeutic Recreation Association and National Council of Therapeutic Recreation Certification. She is recognized as the American Therapeutic Recreation Association's Member of the Year in 2003 and in 2011 was awarded the Scholarly Achievement Award. In 2012, Dr. Richardson took on the role of Editor-in-Chief of the American Therapeutic Recreation Journal. So we really have some esteemed faculty presenting today, and I'm anxious to hear what they have to say to us. So at this point, I will mute my mic.
Okay. I guess we're ready to start. I just wanted to say that we have a lot of information. I hear an echo. Does everybody else hear it?
Yes.
Yeah, I hear
Okay, I'm not quite sure how to correct that.
it might be sitting too close to Sharon.
Okay, I have to get away from Sharon.
Or if it would help if Sharon, you just kept muted until you needed to speak to. So.
Okay.
Okay.
Okay. All right. All right. So how is that? That's a lot better, I think. Okay. So we have a lot of information to share today. So I'm going to be going through a lot of information very quickly. Certainly we have resources and you can follow up. I'm sorry, Dean, do you hear? It's not coming out that clear, so I'm not quite sure.
Yeah, Sharon's microphone still wasn't muted, so I muted her for now.
Okay. Okay, Sharon, are you okay? All right, can everyone hear me now? Dean, can you hear me?
Yeah, I can hear you great now.
Don't hear it. Okay, how's that?
It sounds great to me. Anybody else having any problems?
Okay. All right, good. Okay, so these are the learning objectives. I'm not going to go through it in detail, but we certainly want to give you an introduction to the therapeutic recreation field. Okay. Everything's okay? Identify the role TR plays in geriatric care across settings, and examine the current research in the field. Okay, so, all right. So first of all, the name. All right, so you probably noticed by now we've been using the word therapeutic recreation. We also use recreation therapy. We talk about recreation therapists. And there's also something known as the Certified Therapeutic Recreation Specialist, which is CTRS, and that's the certification in the field. So for the purposes of this, we're not going to get into too much detail about that, but you know, the names are often used interchangeably out in the field. For the most part, recreational therapist is preferred, as is just saying CTRS. Okay, the clinical origins in the field, again, I'm not going to go into details. We could spend several weeks in a semester on this, but we have both clinical and community origins, and you can see from the list that many of us in different professions share our origins with different professions. So certainly with the nursing profession and medicine, we have a background in shared history. So Pinnell and Turk are two individuals who addressed recreation in the treatment of people with mental health and the benefits of recreation participation. And of course, Florence Nightingale who believed that recreation had value to individuals when they were recovering from illness, and created the Inkerman's Cafe, the coffee house where recreation activities and services were going on. During World War II and World War I, the American Red Cross also recognized the value of recreation in helping people recover from illness, and they too had a coffee house, war hut kind of setup, and provided recreation services for the soldiers to help them recover. Parallel to that was our community origins, the whole settlement house movement, Jane Addams and Hull House, and something called the War Camp Club that was also a Chicago-based organization. And in those instances, recreation was used to also help soldiers recover from the war, but also Jane Addams addressed recreation in the treatment of people with disabilities and special needs. And so this profession has kind of evolved from these two different directions, and in sometime around 1965, those two directions merged into something called the National Therapeutic Recreation Society. So it's just to give you a sense of the beginning of the profession and where we came from. Okay. So one of the things that sometimes happens in the field is we have a lot of different definitions that explains who we are. And Sharon encouraged me, because I had a definition with Robin Kunstler, to use my definition. So here is one definition of therapeutic recreation, which is basically engaging individuals in planned recreation and related experiences in order to improve functioning, health and well-being, and quality of life, while also focusing on the whole person and needed changes in the optimal living environment, recognizing leisure's contribution to the quality of life. So again, one of the things that I think we want to convey when we begin to look at the definition of recreation is, as therapeutic recreation practitioners and recreation therapists, we are both dealing with functional improvements just like any other therapy, but also dealing with this thing called leisure and how that impacts on a person's health and well-being. I added this definition because we have a movement in the field to increase the number of states where recreation therapists are licensed, and this comes from a position paper that is used for licensure, and I put this definition up as well. Systematic process that utilizes recreation and other activity-based interventions based on the assessed needs of individuals with illness and/or disabling conditions. And it goes further in that document to explain the purposeful use of recreation and other select activities and facilitation techniques, that again, the emphasis being based on assessed need, with the intention of this therapy to produce outcomes related to improvement and the maintenance of human functioning. So in reality, when we use the word therapeutic recreation now, we've kind of evolved into looking at therapeutic recreation as kind of an umbrella term that looks at a continuum of services that are provided to people, starting with recreation or recreational therapy, continuing with something called leisure education, okay, which we'll talk about a little bit more later, but certainly recognizing that people often don't have a good understanding of leisure, leading to recreation participation, and then ultimately full inclusion. So I just put down some characteristics of therapeutic recreation to kind of give you a framework for how we operate. First of all, it involves purposeful intervention. And the other distinguishing feature is in a leisure context. So often people say, well, a lot of other therapies use recreation, but what's the difference with TR recreation therapy using recreation? And we like to think of it as this both purposeful intervention, which everybody uses, in this leisure context, okay, meaning that the person enjoys the benefits of both the functional improvements that we're attempting to create for that individual, as well as the benefits that a leisure experience has to provide for them. It's person-centered, and we talk about person-centered care nowadays all the time, but therapeutic recreation and recreation therapy have always been person-centered. It's strength-based. From the early time when I was an NYU student, we learned that we deal with the strengths of the individual first, and we use those strengths to help them deal with the areas that need improvement. It has an ecological perspective. It recognizes that people are part of an overall system that they're interconnected to, and as we treat the person, we often treat the whole system. It often has to do with continuity of lifestyle, which is most appropriate in geriatric care, but that we look at the whole person and look at their lifestyle over a given course of time and incorporate that into our assessment and the way we create outcomes and program plans for them. The other thing we like to talk about in the field is that from the outcome perspective, we address both functional outcomes, which have to do with the everyday things that people need to go on and have a good, healthy lifestyle, and also existential outcomes, which has a lot to do with how a person puts their lives in a meaningful context. So sometimes we even call ourselves the existential therapist, because that is often a focus of what recreation therapists do, but when it's not our primary focus, it's often a benefit that people derive from participating in therapeutic recreation. Okay. So, just briefly, there are certain values and principles that we see as the building blocks, and I'm sure all of you share some of these principles, but things like having a right to leisure. This is something that's been articulated by even the United Nations, that regardless of one's position in life, leisure is necessary for human dignity, and all people have the right to have leisure as an experience. We often talk about autonomy, the right for the person to have choices and to be self-regulated. Obviously, we want people to achieve optimal health, whatever that means within the context of the condition that the person is experiencing. So you may be a person that has a diagnosis of cerebral palsy, but you can have optimal health within the context of that diagnosis. And of course, quality of life, which is, I think, an area that we can be often very successful in more than others in terms of the nature of the experience that people have when they participate in recreation therapy and recreation activities. We also have some core principles. We have a humanistic perspective. You know, we believe that people can grow and change. Again, I mentioned the ecological perspective. We clearly understand that people operate in the context of a dynamic system that they're a part of. We are always aiming for inclusion whenever that is possible. We believe people have that choice, and inclusion is a possibility. And of course, there's this thing called fun, pleasure, and enjoyment, or these things that are called fun, pleasure, and enjoyment, which often is what people think of us as, the fun ladies, okay? And I don't think they usually think of us as the pleasure ladies, but they often think of us as the fun ladies. And sometimes that often is what diminishes how people value what we do. I thought Nancy would enjoy that. So that, you know, we try not to run away from this word fun, because it has value and it has meaning to people. Pleasure often is seen as something that's the opposite of pain, and so again, we know that sometimes there are people that the only thing they can experience is some kind of sensory pleasure, and we have a valuable role to play in that. And lastly, enjoyment. And enjoyment really reflects how deeply a person is involved. And when somebody is fully and deeply involved in something, they're much more intrinsically motivated. So that in terms of what we do, we are always moving towards trying to give a person a maximum experience. So the more enjoyment they get, the more motivated they are. So this is kind of our area of expertise, but it's often the thing that people interpret as the frivolous part about what we do. Okay, so I'm sure all of you in the different professions that you come from have models that act as a guide for professional practice. We have many, many models in our field. Many of them are appropriate to the types of settings that we work in. So it's not a one model fits all kind of model. I just gave you a list to see some of the models. I'm certainly not going to explain all of them. I highlighted a couple of models, the TR outcome model and the interaction model, because I think they have relevancy to the dynamic of working with older adults. And just to give you an example, this is the TR outcome model. And what you can see from the slide is that the TR outcome model addresses numerous functional domains: cognitive, psychological, physical, spiritual, and social, and even leisure is put in there, because we do distinguish leisure as a domain, and it has to do, its focus is on the quality of life. So even when we only improve functional capacity in one domain, we can still help to enhance the person's quality of life. Okay. And for example, someone who's in hospice, Maybe our focus is through our interventions on helping them to find comfort and peace of mind, and we stress that spiritual domain, and the quality of their life in that context hopefully improves, even if the other aspects of their illness cannot improve. So, so this was just one example of one of the models, and there are other models that are applicable to long-term care. So the Bureau of Labor Statistics has also their own definition of recreational therapists, but talks about the employment of recreational therapists is expected to grow 17%, about as fast as the average for all occupations. And the focus has to do with that growth, with the large number of baby boomers coming into aging. Okay. So we are a profession that's growing, and I think that's kind of an underestimation of really how big the profession is going to be. Qualifications are essentially recreational therapist services are delivered by a qualified professional who have been trained and credentialed and certified through the National Council for Therapeutic Recreation Certification. And this slide pretty much outlines the qualifications that are part of the requirements for certification in the field. Okay. There are other number of things I'm going to show you that are the qualifications for certification. So in terms of credentialing, we have a national certification in the field. That's our primary credential. That's the CTRS. It has several ways you can get the CTS, but the primary way is an academic path requiring academic and supportive coursework, 560-hour internship, and the students also have to pass a comprehensive exam that's administered by the Educational Testing Service. We also have specialty certifications, and I might have left one off there, but one of the specialty certifications is in geriatrics, that's all behavioral health and inclusion. So the website you can, off of this, you can go to get more details is nctrc.org. There are 4 states where we actually have licensure. New Hampshire is one of them, Oklahoma, Utah, and North Carolina, and there is a big movement to increase the number of states that have a licensure. Right now I know a licensure activities are going on in New York State and Pennsylvania. So there are over 14,000 CTRSs in the United States. There's far more people who say they practice recreation therapy, but 14,000 people certified. And I have to say, it says United States and Canada, but we have people working as certified recreation therapists in Japan and Bermuda and in different parts of the world. And I know there's a program starting up in South Africa. Rec therapists are required to recertify every 5 years, and it's based on continuing education and professional work experience. There is a detailed job analysis you can take a look at if you want to see more details. There is an employer verification system, so if somebody comes in and says to you they are a CTRS, you can go on to the NCTRC website, put their name in, and verify that. The website also provides resources and marketing materials. There's a system for reporting disciplinary issues, and there's even a continuing education pre-application review to make sure the courses that you're taking in your continuing ed are appropriate for recertification. There's academic preparation right now. There are 2 different programs that are accrediting academic programs. Council on Accreditation of Recreational Therapy Education, CART, is relatively new. Right now there are only 4 universities that are accredited under that program, but that has become, that's growing, and more universities are applying into that program. It's specifically RT focused. The other one is the Council on Accreditation of Parks, Recreation, Tourism, and Related Professions, because we do come, many programs are part of parks and recreation programs, and recreation therapy may be an independent major or it may be an option, and there is a specific set of learning outcomes developed for people who want to go through the certification process with that certifying program. And that program has been around for a while, so you can see there are 79 programs or overall that are, in general, recreation programs that are accredited under that program, and within that there can be other specific TR options or programs accredited. Okay. I'm going to pass this on to Sharon, who's going to talk about the scope of practice.
Great. All right. So the scope of service, so we practice looking at the patients themselves or the clients in terms of looking at doing assessments. We do an initial plan, we design the program, and then implement whatever goals that we've set for the clients. Usually we coordinate in the implementation arena. If, for instance, we set specific goals for the clients and we see that they're not able to attain some of those goals, then we make adjustments accordingly. We're very much tied into the interdisciplinary team. So, for instance, if someone is working in a rehab setting, we are part of that larger team, even though we may have individualized goals that we've set for the client, that we are also focusing on what the team together have come up with for that individual. And then we do an evaluation process where we make a decision if the person has actually reached the outcomes that we've set for them, and then whether or not we need to make adjustments. We do specific documentation from the time the person actually comes into a facility, or if they're living in a nursing home, that the assessment and documentation is very comprehensive. Again, with the scope of service, we are looking totally also at just the management of the particular program, and we oftentimes try to collaborate with universities who might be interested in doing research in a particular area, particularly in a particular setting, working with specific populations. In terms of the interventions, we use various strategies and interventions to assist in helping individuals to achieve their particular goals. A lot of times we may use animal-assisted therapy, we may use assistive aggressive training, or help the individual to maybe modify their behavior, so using behavior modification techniques. We sometimes use expressive creative arts as a treatment modality, assistive technology, cognitive retraining, and various other techniques to help the individuals to attain their particular goals. How do I advance it here? Just hit that down? Oh, it's not. Oh, there we go. In addition to that, what we always keep in mind is whatever the guidelines are in terms of the National Therapeutic Recreation Council in terms of certification guidelines. So we use a systematic process in order to increase the clients that we work with, their opportunities, and help them to improve and to impact on their quality of life. Again, the total goal is to facilitate full participation of the individuals or the clients that we're working with, and to impact their overall quality of life. There we go. Some of the professional associations, and we just have this listed. We have the American Therapeutic Recreation Association, which pretty much set up specific mission statements, and we have a vision statement that guides our practice. But a lot of the guidelines are, again, based on what was established through the NCTRC's guideline. Within the organization, we have specific treatment networks. So you have a network that's specific to geriatrics. Through ATRA, we have opportunities to be able to get continuing education. So they have, for instance, webinars that are available to CTRSs who are trying to keep up with their CEUs. We also, through the ATRA, have a annual journal that comes out once a year, and then we have also the Therapeutic Recreation Journal that comes out of the Parks and Recreation organization. Through ATRA, we have Code of Ethics, and there are 10 Code of Ethics that's included in the ATRA Association. So if you wanted to access research articles specific to therapeutic recreation, you can go to the American Journal of Recreation Therapy or the Therapeutic Recreation Journal. So where do we practice? As you can see, we practice in various settings. Usually, and this information came from the NCTRC's document looking at CTRS profiles. So as you can see, we're in behavioral mental health, 36%, and then the second is geriatric. So we are there in hospitals. Primarily, if you go to a lot of psych hospitals, even in the VA system, you will see us. You'll have recreation therapists that are working there. And then in skilled nursing homes, you will see the CTRS. Depending on the nursing home, you may or may not have individuals who are actually CTRSs. But again, I know in our program we encourage our students as soon as they graduate and they know that they're going into work in a long-term care setting that they go towards their certification. And then the next most popular would be the physical medicine and physical disability area. At this point, I will turn it over to Dr. Richardson. Oh, Dean, can you bring up Dr. Richardson's? Oh, there, she's doing it. Okay.
Hello, everyone. I'm happy to be here. I'm going to talk a little bit about MDS 3.0 and how the implications for that new assessment tool in recreation therapy. First, I think it's important to kind of clarify the differences between an activity coordinator and a recreation therapist. Many healthcare professionals don't realize that recreation therapists are often seen and hold positions in activity departments within long-term care. And as a result, we're underutilized in skilled nursing facilities. Primary job descriptions might be activity coordinator, activity director. But with the new MDS and the recent push to reduce psychoactive medications in older adults, health professionals can help us out and have the opportunity to provide referrals for recreational therapy services. And they could be for things like activity intolerance, anxiety, coping, fatigue, fear, disturbing behaviors, pain, confusion, safety, and a variety of other behavioral concerns or nursing diagnosis that we may be of assistance. So on the left, you'll see typically what an activity coordinator might be, and on the right, you'll see more of what the recreational therapist job is. Certainly, some of the kind of big distinctions are activity coordinators might provide activities that are large group or diversional in nature, are used to kind of entertain or to fill time. The programs that they provide may be led by volunteers. They could be self-guided by the individuals. Some of the staff might be untrained. And they typically might be more focused on attendance and passive in nature, and again, large group. Typically, outcomes aren't measured. In Maine, I know the educational requirements for an activity coordinator are a high school degree with 180 hours of training. And examples might be bingo, listening to music, or bringing animals into facilities. Compared to a recreation therapist, certainly we have some skills dealing specifically with treatment planning and care planning. We're a trained staff. We require active engagement. We're done in smaller groups. I'll talk a little bit later about what the Center for Medicaid and Medicare Services, it's typically a ratio of 1 to 4, 1 staff to 4 people, or one-on-ones. And this provides a lot of opportunities for therapeutic interaction. We measure outcomes, and like Fran was saying, we have a degree and 560 hours of internship experience, as well as the national credential. And these might be specific targeted programs like therapeutic exercise, sensory cooking, preventing falls, and animal-assisted therapy. I just thought it would be important to kind of highlight the differences. If you're in long-term care, sorry, just kind of jumped up. If you're in long-term care, you know that there's been some revisions with the MDS 3.0 compared to 2.0, and these are the sections with the major revisions, and I'm going to go over these sections and then refer to how recreation therapy can help the clients in these sections. And with a specific focus to recreation therapy is in Section O, which was big for us. So Section C is cognitive patterns, and you'll see that they do the brief interview for mental status, as well as a confusion assessment measure for delirium. And certainly these are the sections of the MDS. And again, a variety of people may be familiar with these. But I wanted to focus on the interventions that recreation therapists can do, and then certainly the starred ones are where we have evidence to support those. So again, we're focusing on cognitive patterns and delirium, and we have evidence that supports brain fitness, and typically the recreation therapists are using Sue Fitzsimmons' brain fitness book, and the research that's coming out of our field on brain fitness are based on those interventions that Sue Fitzsimmons has designed. Animal-assisted therapy and reminiscence are the three that have evidence, but certainly there's some emerging science as it relates to bibliotherapy, and then some simple cognitive games, card games, matching games, map types of things, board games, and then computer-based interventions. And another section that was changed is the mood, which is the PHQ-9, and that has to do, certainly you're measuring someone's mood, and do they have little interest? Are they feeling down? Are they trouble falling or staying asleep? No energy, poor appetite, or maybe they're overeating. They may have some fatigue, trouble concentrating, moving or speaking too slowly, and then thoughts of certainly hurting themselves. But as it relates to mood, this is the section that that you work with on the MDS. And these are the potential interventions that recreation therapists can do. And you'll see here that all of these have evidence to support depression. So we have exercise, creative arts, and some of the things that Chani was talking about earlier. Wheelchair bike, which was an intervention developed by Sue Fitzsimmons and Linda Bittner, which is part of a Cochrane review. Animal-assisted therapy, reminiscence again, life review, relaxation, and then cognitive bibliotherapy, which helps the person develop a more adaptive view of themselves and their situation. So here we have some behavioral symptoms, and we have physical, verbal, and kind of other behavioral symptoms that are directed towards others. And thinking about what's the impact on the resident and others, and also under this would be wandering. And again, under Section E, these are this is the behavioral section of the MDS 3.0. But again, some possible interventions. We have simple pleasures items. Simple pleasures items are homemade recreational items that are sensory in nature. And they're typically for middle or later stages of people with dementia. But there's a lot of good research that supports the use of these items. And certainly music interventions. Certainly this is at the meta-analysis stage at this point. Life stories, air mat therapy. Air mat therapy is an intervention that we tested a few years ago. It's really this 10 by 10 mat, that's air mat that's kind of blown up, and it provides frail older adults the opportunity to kind of relax, as well as simple kind of range of motion exercises. and we tested it for agitated wanderers with some good results. And then relaxation, and relaxation is guided imagery, it's seated Tai Chi, as well as progressive muscle relaxation. All three of those have been tested. Cognitive stimulation and social dance clubs, a lot of good research there, expressive arts, and then gardening and horticulture. And again, you see potential interventions for both depression and behaviors have good evidence within the recreation therapy profession. Here we have section F, and oftentimes recreation therapists that are working in the activity department will be responsible for this section. It's the customary routine and activities. And again, if you're familiar with the MDS 3.0, you know that this new interview questions replace those 20 customary routine staff assessment items for residents who can be interviewed. And it's kind of it's a rating scale, and the new interview for activities preferences replaces the staff assessment. So really, again, as you know, the focus on MDS 3.0 is really hearing the voice of the resident. Oops. There we go. Again, this is section F. And then there's a new question as it relates to, does the resident want to return to the community? And that's important for us as recreation therapists to know, because we could do community reentry with the residents. And then certainly for those people who can't be interviewed, staff would provide the information. So there's some major changes in a few areas. And this is section F. The next section has to do with functional status and activities of daily living. And as recreation therapists, we can have an input here too. And again, mobility transfer, toileting, walking, not only in the room, but in the facility, locomotion or mobility, and then dressing upper and lower body, eating and grooming and bathing. Again, all those things for activities of daily living. And that's section G. And this is how you code it. So it just really goes from independent to the activity did not occur at all, and how many assists a person might need. And then there's balance during transitions and walking. So we have activities of daily living as well as balance. So moving from seated to standing, walking, turning around and facing the opposite direction, moving on and off the toilet, and surface-to-surface transfers. And we can certainly help with not only the ADLs, but also the balance types of issues that the client might have through, again, a variety of different interventions. Exercise, again, I mentioned community reentry, and that's certainly a skill that recreation therapists have. Aquatic therapy or water exercise, walking programs, and under that we have animal-assisted therapy, because part of an animal-assisted therapy program could be walking the dog, with assistance from the handler. And oftentimes people are more motivated to walk if they're interested in pets or have a past history in pets, and that's something that they used to do. So I've gotten a lot of people involved in walking programs through simply asking them, will you help me walk my dog? And they're more than willing. And then balloon volleyball or seated chair volleyball, and then a tether ball, which is part of a simple pleasures activity. It's a balloon inside of a sewn material, which kind of slows the ball down, and you hanging it from the ceiling and in a circle. You can use both your upper extremities and lower extremities. And certainly dancing and Tai Chi are all great interventions for these issues that people may have. And here we have falls. And certainly, you're looking at falls during admission, falls during the last 1 to 6 months, anything related to fractures, falls related to prior assessment, and then the number of falls, and the injury, and then major injury. So you're looking at falls history, which is great. But you're also looking at, as far as recreation therapists, we can be very active in falls people that are at risk for falls and falls prevention. And you'll see here there's a lot of evidence in our literature as it relates to helping with falls. Air mat therapy, which I mentioned earlier, any relaxation-based program. Again, I mentioned the seated chair Tai Chi, the guided meditation, and the progressive muscle relaxation. Any walking programs, exercise programs to develop leg strength as well as balance will certainly help with falls. And again, this multi-level recreation falls prevention, Linda Bittner developed a falls prevention program for older adults that deals with, again, it's a multi kind of modal approach, suggesting that some functional fitness program in the morning, some walking program in the afternoon, and some relaxation program in the evening, prevented falls in long-term care. And then certainly horticulture therapy with kind of elevated gardens, again, to help with balance and leg strength. And pain. Pain, as we know, is a multi-dimensional issue. It's not just physical pain that people deal with, but it's emotional and spiritual pain as well. And there's been a pain assessment added to the MDS 3.0, and it's a resident interview as well as a staff assessment of pain if the resident can't self-report. And this is section J, where some of the pain information is collected. And here we just talk about, you know, it's supposed to help us schedule pain management. And again, recreation therapy can be part of this pain management regime. So you can schedule recreation therapy. A variety of interventions will help with that. It could be you could use recreation therapy as a PRN, pain management. And this non-medication intervention for pain, this is where we would certainly fit in here. And the next part just talks about the interview for pain, as far as any pain the last 7 days, the amount of pain, where was it experienced, was it hard to sleep, and was it hard to do your day-to-day types of activities. Oftentimes people don't engage in things that they love to do because of issues around pain. And we all know pain is underreported in long-term care. Again, the whole concept that pain is multidimensional is key here, and that there's a mind-body connection is important as well. And recreation therapy can help. We can help the person cope with the pain by diverting their attention, participating in meaningful kind of relationships may help, and engaging in meaningful activity. So as far as expressing themselves, and maybe that might help alleviate some emotional pain, or maybe divert their attention if they have some physical pain. So it could be storytelling or reminiscence, bibliotherapy, might be good for those types of things, expressive arts. The somatron really is a chair that vibrates and also plays kind of soothing music, and that would calm somebody. And air mat therapy is also a calming, kind of a soothing intervention, as well as the relaxation that we talked about earlier. There's some research out of New York that for those glider rockers, and this was nursing research, that basically said if people were in the glider rockers, they asked for less pain medication. And animal-assisted therapy, there's some good evidence that suggests that interacting with an animal can reduce people's pains. Therapy dolls, exercise, again, things like stretching may help people that have some osteoarthritis. Chair yoga would be the same idea, and chair Tai Chi or aquatic exercise therapy would help there. People that like or are engaged in kind of life roles, those folks that love to, you know, clean up and have responsibilities around the unit, you know, folding clothes or loading the dishwasher or setting the tables, those types of things, again, may help people cope, normalize their environment, divert their attention from their pain, give them something meaningful to do in their day, and it may help with the pain. And then the simple pleasure items, again, those homemade recreational items that I'm talking about, there's a lot of those items that are comforting for people, and that might help as well. And again, these are the sections in the MDS where you might find those things. Other areas where it'd be possible for recreation therapy treatment, certainly nutrition and weight loss through therapeutic cooking programs. Oftentimes we can encourage the residents to eat because they're actually involved in the cooking and smell the food, and or maybe they're cooking something that they really enjoy. So if they're going to cook it, they're more often will eat it. And again, the big push to decrease psychotropic meds in long-term care facilities. We're great at decreasing those disturbing behaviors, so I would utilize recreation therapy for, get some referrals for that, and we're more than happy to help with those things. And same with people that may be using restraints because they're a fall risk. We can help with that, and interventions that would help improve people's gait and balance. And then certainly assisting with nursing and any kind of rehabilitation or restorative care that you may have going on. And then returning to the community, those community reintegration programs. So these are kind of some of the nutritional types of medications where you might find that on this MDS 3.0 too. As far as bowel and bladder control, you might not think a recreation therapist could help there, but certainly we can help hydrate people and certainly provide toileting before and after programs. So certainly we would be able to assist if you needed some help with a client in these areas. And this is section O of the MDS, and if you see at the very bottom, letter F, it says recreation therapy, and this is where if you provide a referral and we get a physician's order, we can track the minutes and the days that we're providing recreation therapy. And this is important, although we're not a reimbursable service, it's important because the federal government is actually tracking how much recreation therapy is actually being utilized. And we were able to get on section O because we used to be on section T, and even though a very small percentage of people were actually implementing that section T, it was meaningful enough for CMS to actually include us in the special treatment and procedures. So what does it require for us to do the recreation therapy part? It doesn't just happen. Again, we talked about lots of definitions, and this is the definition from CMS regarding the MDS 3.0, and it's recreation therapy is therapy ordered by a physician that provides therapeutic stimulation beyond the general activity program in a facility. It's physician ordered, and it must include the frequency, duration, and scope of treatment. And again, these are the requirements from CMS. So they must have a reasonable expectation for improvement. So again, the treatment is designed to restore, rehabilitate, or remediate, improve functioning and independence, or help reduce or eliminate the effects of illness or disability. And we have a limited group size, so 1 staff to 4 clients. It must be provided by a certified therapeutic recreation specialist, and it must be physician ordered, and it must include the scope of treatment, frequency, and duration. And again, as far as the process, we could receive a referral from any healthcare professional, obtain a physician's order, and the order could come also from a nurse practitioner or advanced practice nurse. We can assess the client's functioning. We use valid and reliable tools, obtain that physician's order, establish that care plan, implement the treatment, write treatment notes, and then reevaluate. And either we continue with that same order or we discontinue. We could send people to the general activity program if they improved and they don't need us anymore, or maybe we'd need to revise it and do something else with the resident. So these resources come from the NEST, which is an interdisciplinary approach to treating disturbing behaviors. You can find that through Venture Publishing, Suzanne Fitzsimmons' Brain Fitness book, And then there's also another practice guideline that we have. It's recreation therapy for the treatment of depression. And we have some materials that are available through our national organization, Recreation Therapy in Nursing Homes, and then the Falls monograph. And let's see. Oh, these are just links to those resources. All right, it looks like we have a couple questions. Do you want me to go ahead and answer them?
Surely, go ahead, Nancy.
Okay, so Catherine, can you please repeat the author of the evidence-based brain fitness intervention? Certainly, it's Suzanne Fitzsimmons. And if you look, let's see, on the resources, it's under Venture Publishing. And then Donna, it was mentioned that RT can decrease the use of meds for behavioral disturbances and for mood disorders. Could someone please comment on the role of RT in assisting with the management of insomnia? Actually, Shani, it sounds like you've got some experience with sleep, but I mean, certainly there are some sleep kind of protocols that are out there. But Shani, do you want to address that question? Oh, Shani, muted.
I wanted to, Dean, can you put the slides back to Fran, to our slides?
You're on.
Yeah, thank you. I know we're running out of time, but I just wanted to highlight some of the research. So some of the studies that Nancy mentioned, if I can forward it, it's not advanced. Okay. Yeah, so some of the research that Nancy mentioned is listed here. So she mentioned Dr. Bittner and Sue Fitzsimmons' work. Also, Dr. Richardson Nancy also has some work here, so if you wanted to go to those research studies, you're more than welcome to do so. In addition to that, just to highlight some of the outcomes that we've seen from our studies, that basically a therapeutic recreation intervention is found to be efficacious when working with individuals with dementia for decreasing disturbing behaviors. We have evidence that shows that it reduces apathy and depression symptoms. So, we have a lot of evidence there. Use of life review intervention is mentioned. Nancy mentioned before. The wheelchair bike is also there. So all of those references are there so that you can actually see the evidence, and the research studies that have been done in that area. So, Fran, I don't know if you wanted to wrap up.
Well, I just wanted to say thank you for giving us for additional
Okay.
for giving us this opportunity, and I want to both thank Nancy and Sharon, who did a lot of work to make this happen. I hope you learned a lot, and we're certainly available. You can contact us for additional information and for any questions you might have, since we are running out of time.
Yeah.
But So thank you.
Fran, Nancy, and Sharon, this is Elise. I would like to thank you on behalf of our Faculty Development Collaborative and on behalf of all our scholars. I think this was extraordinarily informative, and I can't tell you how important it was that you touched on all the things that we're concerned with in our curriculum, things like evidence-based practices with regard to falls, delirium, depression, dementia, and pain management and palliative care. Those are certainly evidence-based practices that HRSA is interested in. But most important, I think, are some of the interventions that we can do in lieu of psychotropic medications with the current black box warnings and the high morbidity and mortality with regard to use of psychotropics off-label for management of behaviors in people with dementia. I think some of the suggestions that you provided with regard to therapeutic recreation are extraordinarily important, particularly in the long-term care setting. And I was particularly interested in the aspect of community reentry, because right now with the focus on long-term care services and supports, you know, we're really looking at what we can do to facilitate people's reentry into the community. So this was extraordinarily helpful. I hope that perhaps we can invite you back once again to maybe do something much more focused just on interventions in dementia care. But I want to thank you very much.
That would be great. Thank you.
Thank you.